Thank you, Dr. Adiba. It is not only the lunch was great, but it is very difficult to speak after to be the first post-lunch speaker. But anyway, we'll try. Can we have some less noise in the background, please, because it is disturbing. If people want to talk, they can go out of the room and talk. I have no problems with that. Thank you. So, as you heard, I'm a gastroenterologist. I'm the odd person out, I think, from this symposium, but not really too much, because co-infections are a big and a major problem that we need to sort out still in HIV patients. Now, if I can move my slides. So the state of affairs is that Pakistan is now the largest burdened country for hepatitis C in the world. We have close to 8 million viremic patients out of those 58 million that are denoted down there, which are the latest WHO figures. So huge population to deal with. And this is a meta-analysis which sums up what we are really talking about. And this appeared in 2016 in Lancet. And it looks at 4 population groups. One is the general population. The other one on the top is people having heterosexual behavior. On the left lower is people with the MSMs, and where all the dark red spots are people with injection drug use. And you can see just visually that the prevalence is the highest in people who inject drugs. This is slightly old data, 2016. We've heard that now there may be some shifts in the risk factors to MSMs and so on, but until 2016, this was the biggest factor. In HIV-infected individuals, in the general population, the HCV prevalence was only 2.4%, which reflects the prevalence in the general population. 6.4% in MSMs, but look at what happens in PWIDs, so 82.4%. So the mixture of being a drug user with HIV infection and then with HCV infection is what you get here at about 82% of people infected. And this is also our own figures to some extent. If you look at South and Southeast Asia, the numbers to some extent, the percentages remain the same, but now these are numbers. So the bottom line is that HCV, HIV co-infected, PWIDs in South Asia number something like 200,000, and out of these, 83% were either Hep C, mostly Hep C, or HBV infected. So this is a large group of people that we cannot simply ignore or not treat and diagnose, because if you talk about hepatitis C elimination or viral hepatitis elimination, these groups have to be treated and found out really very vigorously. This is some data from Pakistan. These are multiple studies, so I haven't referenced them. Across PWIDs, HCV infection is 54 to 72%. HPV infection is lower. HBV, it's 3.6 to 5%. The co-infections anywhere between 24 to 93%. I know this is a very heterogeneous number. These were very heterogeneous studies that we can see. But in general, I would say that 70 to 80% of PIVIDs who are HIV positive are also HCV positive. Younger people, lower income groups. What is the problem? What is the problem with the co-infection? And the problem is this. If you look at this is just a chart showing you years to liver decompensation. Years to liver decompensation. And if you look at those lines, I can't see those properly here. I hope you can see them on the slides. The top one is the one where there is HIV RNA is less than 1,000, 65% excess rate. And these are, you would categorize them perhaps as reasonably treated HIV patients. If the HCV RNA is more than 1,000 copies per ml, the excess risk goes to 82%. And these people will decompensate very quickly, much quicker than other people, at a mean years of something like 5 or 6 years. And when they decompensate, the only thing that will save them will be an expensive liver transplantation. If you look at the CD4 counts, the story is the same. CD4 counts less than 200, 203% excess risk of decompensation, as opposed to patients who are not infected with HCV infection, not co-infected. If the CD4 count is more than 200, the risk still remains at 56 to 63% excess. So, So why is the liver disease so progressive? And there are many theories. This is just one pathogenesis theory. There is a leaky gut that develops because of the CD4 positive depletion. That gut allows microbial translocation into the liver, and the liver then responds with altered lipid metabolism and gets fatty. The liver steatosis becomes a very important part of this liver injury. So combine this with liver steatosis, with the viral infection itself, with the HIV infection itself. On top of that, combine this with toxicity of ART for the liver, you get really a mix which is not only dangerous but also very difficult to manage sometimes. This is a rather old slide. I put this up to show you what has changed. So in 2008, according to this Archives of Internal Medicine study, HIV/AIDS was the most important cause of death, except for others. 30% of people who were dying because of HIV infection and its complications. Liver mortality was low, or much lower, less than 15%. Cardiovascular mortality was even lower. If you look at another study in 2015, which I haven't put it on the slides, the most important mortality was liver. Most patients were dying because of liver disease, because by that time HIV treatment had been refined, it had been widely practiced, and therefore less and less people were dying from HIV/AIDS. Now maybe there's a competition between liver mortality and cardiovascular mortality. We don't know, we don't have good data on this. But the important thing remains that liver mortality is something that is very important to consider here. So, having said that we have the largest burden of hepatitis C virus infection, there are some silver linings that we've got to use to our advantage. And this is the first one. The combination of SOF and DEC we can get for $30 per month, so that in less than $100 we can cure a patient of hepatitis C with SOF and DEC, with generic SOF and DEC. And we've got 2 or 3 combinations which are generic, which is SOF and WEL, which is slightly more expensive but obviously slightly more potent. So when this paper came out, this was music to us, because this is the combination that we are using or have been using for the longest period of time, because it is the cheapest combination that we have available, as I mentioned. SOF and DEC is not acknowledged by many guidelines to be what you call a pan-genotypic regimen, but we have used it to great use, and as this paper shows, the cure rates are anywhere from 97% to 98%. They only drop if we reduce treatment to 8 weeks, 12 weeks of treatment. 97 to 98% of patients are getting cured. So this is something really which is possibly the lowest hanging fruit in all of this milieu that I've mentioned to you. And the other important thing to remember is, no matter whatever combination you use, the patient that responds, who's HIV negative, and the patients who's HIV positive respond in exactly the same manner. 95% to 99% what we call sustained virological response in monoinfection, and the same in co-infections. So no difference in the treatment response for these patients who may be co-infected. So here are some scenarios where decisions need to be made by the treating physicians, the treating team, of what happens. So faced with a co-infected patient, all persons, and these are recommendations from the ASSLD and the Infectious Disease Society of the US, all persons with HIV should be treated with potent ART, especially those with HIV/HCV infection, HIV infection is independently associated with HCV disease progression, as I've already shown you. HCV treatment should be a priority for persons with HCV-HIV co-infection, even though adverse and efficacy and adverse event rates among those with HIV co-infection may be slightly higher, but they're generally similar to those observed with HCV alone. Co-treatment requires continued awareness and attention to the complex drug-drug interaction. This is something that we will return to. So, if you're faced with a person who's taking ART with HIV with RNA suppression, who plans to initiate HCV-DAA therapy, the only thing you need to be aware of is the selection of the DAA regimen that you're using does not have drug-drug interactions with the ones with the ART regimens. And that really is the only intellectual thing that you need to do about this. Otherwise, it's simple and plain. Patients not taking ART who plan to initiate HCV-DAA therapy, some people suggest which infection to treat first or whether to start both treatments simultaneously. That is sometimes a decision that needs to be made. Having said that, HIV is short-term treatment, 12 weeks at the most, and HCV, of course, is longer-term treatment. So you could decide what you want to do. For many patients, initiation of ART should be prioritized. However, HIV treatment and HIV RNA suppression are not required before HCV DAAs are given, right? So treatment readiness for 8 to 12 weeks of HCC, weeks of HCV DAAs may be different than for lifelong ART. HCV treatment and cure may furthermore serve to facilitate HIV care management because these patients are then now in the treatment cycle and so on. Having said that, ART has some issues with liver toxicity, and getting rid of the HCV infection before starting ART may reduce the risk of drug-induced liver injury due to the ART. Sorry, this is not moving. So just one more guideline. This is the NIH guideline. This is the latest one, which is March 23, I believe. And similar things, all patients should be treated. At high risk should be screened annually, and whenever incident HCV infection is suspected, ART should be initiated in all patients with co-infection, regardless of whatever parameters you wish to use. The benefits of ART outweigh concerns regarding drug-induced liver injury. And therefore, the only thing that remains to be looked at are the HCV drug-drug interactions. Many websites and many resources available to very quickly look at drug-drug interactions. And this is, for example, one example from the European Society of Liver Disease. Sorry, this is not. Yeah. So it will immediately show you that this administration of this combination with the ART given on the left column is going to be difficult. And so it's very easy. Just people need to be educated about how to access these things. There is a University of Liverpool website, which is the best one, I suppose, because it's very, very quickly updated all the time, and you get all the things from there. There's one more consideration. If there is hepatitis B infection in a HCV-HIV co-infected patient, the HCV treatment may reignite the HBV infection, may make it active again. And therefore, the patients who are triple infected should receive a hepatitis B treatment while they are being treated for HCV infection in these patients. Risk of HBV reactivation is very low in patients who just have anti-HBC or anti-HBS, which means that they have indolent infection, indolent B infection, and not active infection. The risk of reactivation is very low, but they still need to be monitored during treatment. Please remember that the HCV cure does not mean end of engagement with that patient, because we know these patients are at risk of reinfections. We know that these patients may still be at risk of disease progression, particularly if we started treating them at an advanced stage of fibrosis which is stage 3 or stage 4, according to various classifications. So finally, just a couple of slides on HBV, HIV. This is a lesser of a problem, as I mentioned, in terms of prevalence. And the other good thing is that really many of the medications that we're using for HIV treatment are also useful for hepatitis B treatments, such as TDF, TAF, LAM, etc., etc. 3-drug ART containing TDF or TAF provide effective treatment for both viruses. So really there's nothing, again, nothing intellectual that needs to be done here except to continue treatment. If tenofovir is contraindicated, entecavir can be prescribed in addition to the other ART drugs. So just to conclude, HBV, HIV co-infection is common, or very common, I should say, particularly in PWIDs. It has connotations because it has become one of the leading causes of mortality in these patients that are otherwise will not die of HIV but will die of liver disease. Effective treatment is available for both HCV and HIV. HCV treatment is curative, HBV treatment is control, and therefore there is every reason to treat these infections. In the recommendations, we know that, and we will discuss this in a panel discussion, there is lack of integration between the HIV programs and the viral hepatitis programs. One is vertical, one is horizontal. They don't talk very much to each other, they don't interact very much with each other, and I would be interested to hear comments from the lady from UNICEF, I'm sorry I forget her name, about how she feels that there is integration at the level of the PMTCT, for example. So we need to define the care pathways of co-infected patients very carefully. We need to educate the PWID or HIV community about the vulnerability of liver disease. They may pay due attention to their HIV, but they may not be well educated in their co-infections here. Simplify further the HCV treatment of co-infected patients, and by that I mean we've discussed the one-shot or two-shot long-term solution for HIV. Maybe there is something coming as a one-shot or a two-shot solution for hepatitis C. So I'll stop there. I know that there are many other co-infections that we could have covered, but I wanted to concentrate on HCV because this is our major problem. Thank you.